Hello, I'm Dr. Tariq. The purpose of this short video is to educate primary care doctors about basic management of migraine and tension type headaches. The main goal is to reduce the wait times for headache referrals at neurology clinics. All right, so let's start. First, making a diagnosis. So we have a website, International Classification of Headache Disorders. They have mentioned all the criterias for different types of headaches and facial pain. So if there's some confusion about a headache diagnosis, I would highly recommend going to this website and reviewing the criterias. Now, if a patient walks into the clinic with a throbbing, pounding headache with either nausea or light and sound sensitivity, then this is very likely a migraine. In addition, patients may also have coexisting tension type headaches, which present as a band like pressure feeling or a tightness around the head. Now, most common presentation in headache clinics is actually a mix of both tension type and migraine features. Now, if we see both tension and migraine features, we treat it as a migraine because treatments essentially are the same for both migraine and tension type headaches. In fact, there are studies which have shown that even triptans can help tension type headaches. So, once the diagnosis is made, the most important question to ask a patient is how many days a month do they get a headache? Because this is important to know. This depends based on the treatments we're going to decide in the future if preventative has to be given or if response to the drug has to be determined, then this question has to be asked. Now, according to American Headache Society, the recommendations are that if patients have 4 or more days a month of headaches for 3 consecutive months, then they would benefit from a preventative medicine. The reason why we start preventative is to prevent the episodic headaches from becoming chronic, which means 15 or more days a month. The goal of abortives is to take away the headache within 2 hours. Now, in some cases, we do repeat the same medicine after 2 hours if the headache has not gone. The goals of abortives are 2-hour pain freedom. Triptans, there are 7 triptans approved by the FDA since 1991. If triptan A did not work but did not give any significant side effects, then we do encourage providers to try any other triptans before moving to any other class. Now, we also have these oral anti-CGRP class of drugs available that can be used as an abortive. Rimagepant and ubrogepant are the ones that are available now at the moment as abortive medicines. Now, correct dosing of medicines is important. Sometimes the doses are subtherapeutic. For example, we see that sumatriptan is tried at 25 milligrams and it didn't work. Typically, at such a lower dose, it usually doesn't work. In the preventative category, these medicines are typically given daily or monthly in case of the injections. The goal is to drop the headaches to 50% in severity and frequency, which is number of days per month after 3 months of using it. So we recommend to start at a lower dose and then wait for a few weeks to show any benefit. Tricyclics, these are in the antidepressant category. Amitriptyline, nortriptyline, typically started at 10 milligram or 25 milligrams at bedtime. Some patients may have constipation, some may have weight gain. It increases appetite. SNRIs, the duloxetine and venlafaxine are the ones we use. Again, lower doses and going up on weekly intervals. They may cause nausea in some cases. They're typically considered weight-neutral drugs. Now, we have anti-blood pressure class of medicines. We use propranolol extended release or nadolol, again, once a day. Also, verapamil is another drug. Side effects may include dizziness and lightheadedness. We ask patients to check their blood pressure and pulse, and if it's low, we either reduce the drugs or we stop it. Topiramate is in the anti-seizure class. It has several randomized controlled trials showing efficacy in migraine prevention. The side effects may include up to 4% of patients can have a kidney stone. Therefore, we tell patients to drink plenty of water. It can also cause some cognitive side effects. And in those cases, we sometimes decrease the dose or we stop it. It is also contraindicated in pregnancy. Then we have the new anti-CGRP class, atogepant 60 milligrams daily. Rimagepant, Nurtec is approved for both as a abortive medicine and also as a preventative every other day. Then we have monthly subcutaneous injections, erunumab, fremanezumab, and galcanezumab. The discontinuation rate is very low. They have in general considered to have less side effects than the other drugs I mentioned. Now, pitfalls in migraine diagnosis: cluster headaches, more common in males, smokers. They have ipsilateral autonomic symptoms, meaning on the same side of the headache, they may have droopy eye, tearing of the eye, redness, and then nasal congestion, to name a few. Cluster patients are restless. They pace during the cluster attacks. Migraine patients typically do the opposite. They go in a dark, quiet room. Migraine lasts several hours to days. Cluster typically lasts 1 to 2 hours, even without treatment. Now, hemicrania continua. This is a one-sided headache, similar to cluster, but it's a constant daily headache, 24/7 for months. And then it also has these one-sided autonomic symptoms. Sinus headaches, if patients have a greenish yellow discharge, nasal discharge with imaging evidence of sinusitis, then it should be considered a sinus headache. A lot of times, sinus headaches actually turn out to be migraine if they have clear nasal discharge and they have migraine features of light, sound sensitivity, nausea, throbbing, pounding pain. Migraines can coexist with cervicogenic headaches, meaning neck-related headaches, and also TMJ dysfunction, which is typically tenderness in the jaw as well as in the temples. Now, when to refer migraine to neurology clinics, we encourage PCPs to try at least one abortive medicine and one preventative for at least 3 months, unless they have side effects, before referring patients to neurology. And if patients have chronic daily headaches, they can be referred directly to neurology. Patients with contraindications to conventional treatment options like triptans, for example, if they had a stroke, coronary artery disease, if they have history of any dissection in any of the arteries, and then if PCPs have polypharmacy concerns, then migraine headaches with some atypical features, hemiplegia, numbness, facial pain with headaches. There are some overlapping features, not clear if it's cluster, trigeminal neuralgia, sunk headache, or migraine. If there's a positional component, headaches going away when lying flat, then it should be suspicious for CSF leak. They can be referred to neurology. Patients who are overusing over-the-counter medicines and not getting better. All right. Then what neurology can offer, they can confirm or change the diagnosis. Neurology can offer more imaging. They can investigate CSF leaks, high pressure headaches, obstructive sleep apnea related headaches. All right. And then other treatment options neurology can offer are occipital and supraorbital nerve blocks, Botox, outpatient IV infusions for refractory headaches, sometimes inpatient admission. FDA has cleared a few neurostimulation devices for migraine prevention. Then neurology can also use some second, third, and fourth tier drugs not mentioned in the previous slides. Neurology can also involve ancillary services like cognitive behavioral therapy for refractory headaches, also post-concussive migraines with other symptoms besides headache. Another good resource is e-consult order under Epic for any quick questions on patients, drug interactions, confirming contraindications. Any headache-related questions can be sent to us through this service. All right. Thank you.